Well, welcome to Fox 8 Extra. I'm Stefani Schaefer. For every 8 women that you know, at least one of them will be diagnosed with breast cancer in her lifetime. Aside from skin cancer, it is the most common cancer in women in the U.S. Every October, of course, we wear our pink to raise awareness, but we really want to talk about the importance of early detection, of symptoms, of treatment. And joining me now is my friend, Dr. Natalie Joseph from Metro Health Medical Center. It's a pleasure to have you here today, and we're devoting this entire half hour to breast cancer. You will learn so much. So this is for everyone, men too, to support the women in their lives, but also men cannot escape breast cancer either.
That is correct. So thank you, first of all, for having me, Stephanie. I'm always happy to talk about this topic because it's something near and dear to my heart, and one that I think that we have the ability to influence the outcome for patients. And as you mentioned, it's not just women, although only 1% of patients who get breast cancer are men. Men are not immune. So even if men notice something that's abnormal or different, they should also get checked out too.
It's oftentimes even men may even notice something's different with their wives or their partner's breast, that a lot of times I've heard from people saying it was actually my husband who said something doesn't look right. Or,
yeah.
And a lot of times it is the man who's encouraging the woman in their life to get things checked. You've been a surgeon, you remove breast cancer every day. Talk a little bit about that and what you're seeing. So you are at Metro Health Medical Center.
Yeah, so I've been at Metro now for 17 years. So I'm a surgical oncologist, which is a cancer surgeon, although my specialty area is in breast cancer. With how we manage breast cancer, and actually how we manage many cancers, it's very much a team approach. So we work with a multidisciplinary team, includes myself as a surgeon and other surgeons, as well as medical oncologists, radiation oncologists, and a whole host of other people who really help to navigate patients through their treatment and get them through all facets of their treatment. What I do when patients are newly diagnosed, or sometimes they come to me when a new abnormality has been noticed or they have an abnormal mammogram, I'll sit with them. I go through their history, their family history. We'll obviously examine them just so that I can understand the extent of their cancer. And then I'll just walk them through what the diagnosis actually means and what the options are for surgery, and then obviously do their surgery as well. And sometimes, for example, for patients who are undergoing mastectomy, we work very closely with our plastic surgery colleagues, and we'll do reconstruction many times at the same time. So very much a team approach to how we take care of patients.
It certainly has changed over the years, and it doesn't always mean chemo and radiation and removing both breasts, or, before it used to be a very grim diagnosis, but now would you say more awareness is helping? That's what we try to do all the time, is talk more about the awareness, also new guidelines for screening, and then new procedures, new treatments. Would you say that is the reason why it's not a grim diagnosis anymore?
Yeah, absolutely. I think it's a little bit of all of the above. I think with awareness, people are getting screened, and so therefore we find breast cancers much earlier than we used to. And so we have many more options when we find them earlier. And when you have an early diagnosis, your long-term outcome and chance for cure and good long-term survival is excellent. Also, I think with just the types of treatments that we do, just as you said, in the past it used to be that when a woman had a diagnosis of breast cancer, the only treatment was given a mastectomy. And actually many decades ago, it was a very gruesome operation where they not only to remove the breast tissue, they removed the muscles of the chest wall, so it was very disfiguring. And we have really come a long way, I'm glad to say. Now I would say the majority of our patients, if their cancers are found in an early stage, we can do what we call breast conserving surgery, where we're really only removing the cancer, just with a margin of normal tissue around it, maybe do a small incision under the armpit area to remove lymph nodes, and then that patient may get radiation therapy. And then even for those, as I mentioned before, who need a mastectomy, they can get reconstruction. So many times their cosmetic outcome actually looks quite nice. And we can even, now we can have the ability in some patients, not every patient, to spare all of their skin and the nipple as well. So we give them the best cosmetic result that we can. There are also newer techniques being discovered. So in fact, just I think 2 weeks ago, a newly approved procedure called cryoablation was just approved by the FDA. So for a very small subset of patients, some of our older patients who may have very small, low-risk cancers, we can actually just freeze those cancers as opposed to even taking them out.
Wow.
Yeah, and I think also just some of the treatments have evolved. So our understanding of breast cancer has evolved. So now we really target each treatment to the individual. And there are some instances where we can treat patients up front with chemotherapy and really shrink their tumors down so that someone who might have needed a mastectomy when I first met them, we can make the cancer small enough that then I can just do a partial instead. So it's really, as I said, many areas of treatment have all improved and really to the advantage of the patients.
And some of the medications too are a lot better, not as tough on a woman's body, like tamoxifen, and even helping to prolong life after breast cancer.
Right, so for some patients whose cancers express the estrogen or progesterone receptor, hormone receptors, we can target treatments to those receptors after they've gone through their treatment. And that will, patients typically stay on them for at least 5 years, and that helps to reduce their risk of getting subsequent cancer in the future, and it reduces the risk in both breasts. We also give a different type of estrogen blocker to women who are postmenopausal, so it's not like one size fits all. So a different subtype of estrogen blockers called aromatase inhibitors are given to those patients. And then also, again, because of our understanding of some of the biology of specific cancers, there are other targeted treatments that we give as well. So there's a medication, for example, called Herceptin, which targets the HER2 receptor. And in some patients who have more advanced cancers, we also can give them immunotherapy or other targeted agents that help to really enhance the action of the other drugs that we're giving as well.
It's amazing, and that's why a lot of times we do these walks and charity events, because not only do we want to raise awareness and really encourage all women to get checked, but it's also raising money too to help support a lot of this research and a lot of this stuff that is now leading us into a completely different path with treatments. Let's talk about when women need to get that first mammogram, always doing self-exams, very early age. What age would you say that a young woman should start doing their exams once a month, getting to know their breasts and what feels right but what doesn't feel right?
Right. So interestingly, many of the national guidelines for screening have eliminated self-examination as what we would call a recommendation. But that being said, I always tell of my patients that you really should be familiar with what things feel like. So I think definitely at least by maybe in your 30s, people should start to pay more attention to that.
And even younger women, I'm sure. I mean, I know you've seen girls in their 20s. So if you feel something that doesn't seem right, whether you're in the shower and you're washing or you're putting lotion on or whatever,
right.
Don't think that it just doesn't happen until you're in your 30s.
Yeah, you're absolutely right. So just as you said, if you're in the shower, sometimes if you're laying down, if you feel something, if your partner feels something, you should definitely get it checked out. For sure, I think most women, once they hit their 30s, should start paying much more attention to kind of overall risk assessment. So if you go into your primary care physician or your gynecologist, they should at least be asking you about your family history and looking at other risk factors that you may have to determine whether or not we should be screening you differently or more frequently or more aggressively. For average risk women, they really should start screening at age 40, which is what the American Cancer Society guidelines are. I think there's hard evidence for starting by age 45 and going annually, but really you should start as early as age 40. And if you have a first-degree relative, like a mother or sister who may have had breast cancer, you should start 10 years earlier than their age of diagnosis as well.
So maybe at 30. Like I had my first baseline mammogram at 40.
Yeah.
And then also, Carrie, you have to weigh in on this too, because I think it's something you and I both been dealing with, and a lot of women do too, which is this dense tissue. So they want to establish a baseline because all women's breasts are a little different sometimes.
Yeah.
And that can really help to see if there are any changes that may progress yearly.
Right, exactly. So many women have dense breast tissue, so it's not an abnormality, it's actually kind of a normal variant. About 50% of women are dense. There are 10% of those are extremely dense, and then about 40% are kind of what we call moderately or heterogeneously dense. And what breast density is, it just means that you've got more of that kind of glandular tissue in the breast tissue. But the one thing about breast density is that it can make it harder for things to be seen on your mammogram. So a mammogram may not be as sensitive in someone who's very dense. There are about 10% of breast cancers that we don't see on a mammogram, for example. And so the other part of that is that breast density is an independent risk factor for breast cancer. So, and it's thought to be for two reasons. One, because you don't see things as well, so you might miss them or they might go along a little longer before you find them, but also because you have more of that glandular tissue, there's more tissue that's at risk. What is, I think it's been about at least 5 years or so now that there was a federal mandate that for any woman who is identified as having dense breast tissue, they have to be notified of that. So you'll see that on your mammogram report that you have dense breast tissue. And it also gives you the option to then get supplemental screening. And that can be, at Metro Health, for example, we use what's called automated breast ultrasound, which is just as it sounds, it's an automated ultrasound. It's managed by a technician, but it will ultrasound the whole breast. Some places will use a rapid MRI protocol as well. And using those other modalities gives us another way to look at your breast tissue that may be a little more sensitive, and you pair it together with the mammogram to really get a good look. The nice thing is that we do find extra cancers, sometimes cancers that we may not have seen by just getting a mammogram in those patients. So we do recommend to women that if you have dense breast tissue, at least have that conversation with your physician about getting that supplemental screening. The downside is not all insurances cover it. So sometimes you do get stuck with an out-of-pocket cost. So you really you might want to talk to your insurance company as well.
Well, hopefully that will change now that this has been now a standard that is established and recognized. Every year, it seemed for many, many years, I would have the mammogram, and then they'd say, "We stick around. We're going to wait till technician. Let's also do an ultrasound and then an MRI." It was always a stressful, long day. But then you feel like, okay, I've been triple checked, and then talk to the doctor. Go, it's exhausting. Carrie, you had
this is my question for you, because in my case, it was an out-of-pocket test that I had to do afterwards, which I was happy to do, and found out I was good to go. But then my next mammogram, I got the same letter, which I know is federal mandate. Should I continue doing these out-of-pocket tests every single time? Or should I, that's where...
Yeah, we do recommend that. I mean, if you're able to, we would recommend doing it actually each time. And breast density does change. So it can change with age, it can change with, your weight. And so you could be dense, as you're younger, for example, and as you get a little bit older, you may not be, and you may not need to continue doing them. But yeah.
All right, so let's talk about some of the treatments too. So a woman finds out she has breast cancer, and I know the treatment varies with all different levels of breast cancer, but let's talk about what a woman would face with treatment.
So, as I mentioned before, many times as a surgeon, sometimes I'd say most of the time, I'm one of the first people that patient will see. And the first thing we do is really explain to the patient the specifics of their cancer. So what type it is. For example, we look at receptor profiles, as I mentioned before. There are 3 receptors that we test for, and they're really important because they can guide what type of treatment we give you, and also sometimes the sequence in which we give it as well. And then now I think in this modern era, we use what's called genomic profiling, which is actually us taking a look at your specific cancer and doing a molecular profile of that cancer. And it helps us to predict the behavior. And that can also be used to help guide treatment decisions, such as whether or not you might need chemotherapy or not. So, for example, in women who have cancers that either do not express the estrogen receptor or who do express that HER2 receptor I mentioned before, those patients many times will treat them with chemotherapy first, because those are more aggressive forms of cancer that have a much higher risk of coming back in another location outside of the breast. So we treat them with chemotherapy first, and it has 2 benefits. One is it could shrink the cancer, but also it improves patient survival in those instances. And actually, even though those are considered to be more aggressive cancers, now we're seeing such amazing response rates to those that about 20% of patients will have what's called a complete pathologic response, meaning that when I do their surgery, I don't even find any more live cancer cells in that tissue that's removed. And those patients really do quite well.
That's fascinating. Talk before we go to break about the partnership that you have with the American Cancer Society at Metro Hospital.
Yeah, so actually we've had a really long partnership with the American Cancer Society over, I think, clearly over 10 to 15 years. American Cancer Society has been very involved we've received some community grants from them, which have allowed us to provide some resources to our patients, like patients who may have needed help with transportation or their electric bills or those types of things. We also had several years ago, one of our first navigators was an American Cancer Society navigator that was embedded at Metro Health. And now, although that program doesn't exist anymore, we obviously have our own, but that really helped us to launch that program. So we've really had, as I said, a long and lasting partnership. We're always happy to support the American Cancer Society and their causes. And of course, we have the Making Strides Walk coming up this Saturday, of which of course we have our Metro Health team.
That is wonderful.
Yeah.
Well, we do still have so much to talk about. I feel like we're just scraping the tip of the iceberg right now, but please stay close. When we come back, we're going to talk with about a lesser known form of breast cancer that is on the rise and important symptoms. We've got all the information, many more details when Fox 8 News Extra, Fox 8 Extra returns. So stay with us. Welcome back to Fox 8 Extra. This month, the American Cancer Society released new statistics about a lesser known form of breast cancer, lobular breast cancer. And breast cancer detection is actually harder to detect on mammograms, and now it makes up more than 1 in 10 cases in the U.S. I'm joined once again by Dr. Natalie Joseph from Metro Health Medical Center, and also from the American Cancer Society, Haley Dorflinger is Associate Director of Cancer Center Partnerships with the American Cancer Society. Ladies, thank you both for being with us. Appreciate it. Let's talk about this new form of cancer that you're seeing more and more, and why do you think we're seeing it?
Yeah, so lobular cancer is not necessarily a new form, it's just that it's becoming a little more prevalent. So the majority of breast cancers are of the ductal type, or invasive ductal, so it means that they arise from the cells lining the milk ducts in the breast tissue. And those milk ducts terminate in glands, or lobules, and about 10% of all breast cancers arise in the lobules. So we're seeing more lobular cancer, and I think that's what the American Cancer Society study just demonstrated, that there is a rise in that subtype of breast cancer. One of the reasons why it's a little more challenging is that lobular cancers can many times not present in quite the same way. They don't necessarily form a nice discrete lump or mass that we can see on a mammogram. It can be more diffuse, and so therefore it can be harder to detect. What we do know, though, is when we do find it, we tend to do some additional testing to make sure that we're not just seeing the tip of the iceberg. So it allows us to be much more precise about how we treat it. So, for example, in many lobular cancers, in addition to getting the mammogram, once we've diagnosed it, we'll get an MRI as well, which is a little more sensitive way for us to be able to see the full extent of the cancer.
Let's talk about what you think could be the cause of cancer. And I know the American Cancer Society dives into all of this research, but what are some of the risk factors? Haley, maybe if you don't mind addressing that for women.
Yeah, absolutely. First, I would say thank you for having me.
Of course,
it is
welcome.
a big month for us, being Breast Cancer Awareness Month, and we're celebrating 40 years. So just celebrating the progress that we've seen, and you talk about risk factors, and I think that's speaks to the progress we've made.
Yes.
While there are so many things to learn still about breast cancer specifically, there are risk factors that we know of, and the American Cancer Society actually has a tool called Cancer Risk 360 that you can take on your own. It's about a 5 to 10 minute assessment, and it does speak to some of these risk factors, right? What is your adherence to screening? We talked about getting your mammogram. What is your adherence? What is your knowledge? Alcohol consumption. What is your nutrition like? What is your physical activity? And at the end of that, you get a really nice report that helps guide you to make good decisions to take action on those risk factors that you can control.
And sadly, we see too the population of African American women that aren't getting screened as much as they should, and a higher risk of having breast cancer, dying from breast cancer. But you guys are really doing important things to get in the community, get out there, get the word out there. We've kind of been working together in order to do that too. Yeah. Let's talk about that.
Yeah, absolutely. So speaking of progress, so 40 years ago when we launched Breast Cancer Awareness Month, it was about 1 in 3 women overall were getting their mammogram, and we're now looking at about a stat of 2 out of 3. So there's progress that's being made. But when you talk about Black women specifically, we actually see less diagnosis but more negative outcomes. outcomes. So we have a lot of work to do to overcome the disparities that exist for a variety of reasons. But one of the big ways that we're taking action is through our Voices of Black Women study, which is a study where we're looking for 100,000 Black women across the country who have not received a cancer diagnosis to sign up, answer some questions, and help us to hopefully understand why these disparities exist, with the ultimate goal of having better outcomes.
So if people want to, that are watching right now, participate in this, how can they contact you?
Yeah, absolutely. I think cancer.org is the best place to go for all of this information. We're going to talk about a lot of things today, and ACS offers so many resources. So cancer.org is the best place. You can search Voices there, but you can also go to the website for Voices as well through cancer.org.
And Dr. Joseph, if you don't mind touching base on that, I think so many people are scared and they just think, I don't want to know. But this is a cancer that if it's caught early, you'll be fine. And I think that's the thing, is so many people are so hesitant, and women are afraid, and they may be raising a family or taking care of a loved one or being a caretaker, whatever it may be, and just thinking, I don't want to know. But you need to get there. If you don't mind, just give that to our audience today.
Yeah, I think you're absolutely correct, Stephanie. I think people are afraid of the diagnosis, but I always tell people it is absolutely, not a death sentence, and particularly if you get screened and you find it early, it is very curable. We have many, millions of survivors of breast cancer every day. I think sometimes people feel that if getting their mammogram doesn't prevent them from getting breast cancer. The whole point of doing it is so that we find it early. The other thing that we always try to reiterate to patients is that even if you don't have a family history, you can still have risk, because as we mentioned before, 1 in 8 women of average risk women will be diagnosed, and 75% of patients who are diagnosed with breast cancer do not have a family history. So that's why screening is so important and why it's important to go. With regard to African American women, I think that as Haley mentioned, although the incidence of breast cancer isn't as high in the African American population, they have a much higher likelihood of dying from the disease when we compare them to other ethnic groups. And that can be for many, many reasons. But one of the things we do know is that there's a higher incidence of some of the more aggressive types of breast cancer, like triple negative breast cancer in Black women as well. So another reason why I think the call to action for all women, but particularly in the Black population, is so important.
And I think a message is so important. Don't wait till you find a lump.
Right.
If you don't mind addressing that before we go.
Yeah, absolutely. I mean, it starts with prevention, and that's so important, just to not be afraid, to your point. We've seen a 40% reduction in mortality from breast cancer, so progress is being made.
Yes.
But the theme for us this year is, it's not just awareness. Like, we have to wear our pink and we have to support awareness, but we have to take action. So get your mammogram, grab your friend, your sister, your mom, work together, go do that, celebrate afterwards with a fun treat. But that screening is so important, and being your own advocate is so important.
And I think that's a wonderful take home, to involve your family, your friends, say, let's do this together. I know you might be afraid, whatever, but we're gonna experience this together. Make it more of a celebration. We've also noticed too that a lot of events that will even have walks or events downtown where we'll see screening vans for women, and they can just pop in there real quick and see a doctor, and you work in partnership with them.
Yeah, absolutely. In my role with the American Cancer Society, I partner with cancer centers like Metro Health across Northern Ohio, and just any way we can get that awareness out about a mammogram, what it is, how to do it, is so important. So absolutely. The only piece I would say is that follow-up is so key. So if you do receive a screening, or you do have a conversation at an American Cancer Society event, follow up with your physician to see what to do with those results. We talked about the dense breast tissue. You'll see that in your results even if you don't receive a diagnosis, but that follow-up is key.
My only hope is that everyone watching today, if you have not been screened and you need that little nudge, I pray to you that I hope that our discussion today is that nudge, that you watch this show and you make that appointment today. At least make the phone call to make the appointment, because it could save your life, and there's a reason why you're watching this. And this is a cancer that is beatable, and we're gonna talk in a year, and you're gonna even have better information and statistics and numbers. Thank you both for being here today. It's just been such a powerful message and so much to learn.
Great. Thank you for having us.
And we're going to get it. Save the tatas, right?
That's right.
Before we go, we also want to let you know October, as we've been talking about, almost over, but there is still time to support one of my dear friend and co-worker Todd Meany's Men Wear Pink campaign for all the guys to help support for the women here with breast cancer. He is raising money for the American Cancer Society. We do have a link on his campaign site, fox8.com. Look under Seen on TV. So they have a wonderful goal. And I can attest every day, even if we're not wearing the color pink on our show, he has something pink on. Usually it's the socks at least, so, or a pink pin or something. But Todd, we want to thank you for all the guys supporting and standing up for that again. Thank you both, ladies. Appreciate you both so much. Thank you.
Thank you. Thank you.
Love you guys. All right, well, thank you so much for being with us. Again, don't forget, make that phone call. Make sure your friends, your neighbors, and your family members have as well. And that's our take home. Thank you. We'll see you again next week. So long.